So, welcome guys to the Med Crash Course series. Today we're doing the final crash course on plastics and breast surgery, taught by Jess Caterson. So in the top right corner, we've got our QR code for our Instagram page. So if you don't follow, please do scan and follow. And in the bottom left corner, we have our email. So if you have any questions, please email us. And just to let you know, this will be up on YouTube as well. Go to the next slide. So this is the QR code for our polls, and I posted the link in the chat as well. So scan and you can vote for each of the SPAs, and it's completely anonymous, so please do try to answer the questions. I'm going to hand over to Jess now.
Cool. So yeah, my name's Jess. I'm currently doing an F3, but I completed my foundation training in London and studied at Oxford before that. And I've got my MRCS and I'm applying to be a surgeon at the moment. So yeah, I'm going to be talking to you about plastic surgery and breast surgery today. So just a quick disclaimer, the contents of these slides are not comprehensive, and please make sure you refer to your local med school guidance about the syllabus that you need to prepare for finals. Also, the answers have been written by myself, so please don't copy them or use them elsewhere. And useful places to look for information and that I used in my own revision with the Oxford Clinical Handbook, Teach Me Surgery and PassMed. So start with plastic surgery. The first SBA is a 45-year-old male that's brought to A&E after sustaining significant burns to his right arm and anterior chest following a house fire. He weighs 75 kilograms. As part of your A to E assessment of this patient, he will require fluid resuscitation. Which one of the following is the most appropriate fluid resuscitation regimen within the first 24 hours of admission? So the answer here is B. This is basically applying the Parkland formula, which I'll show you in a short moment. But the main thing is that you calculate the total volume, which is 8,100 mils in this case, and then you divide it. The first is given in the first 8 hours, and then the second one is given in the next 16 hours. A 6-year-old female sustains a burn to her left hand after knocking over her parents' hot tea at home. On review of the patient, you note a 4 by 5 centimetre burn to the back of the patient's hand. It is dark red in colour with blistering. The burn is mildly painful. Which of the following best describes the burn? So this is a partial deep. So the key features that you need to be aware of here are the dark red colour. In fact, it's blistering and it's painful. A 3-year-old female is brought to A&E by her mother after sustaining a burn to her back and buttock area. Her mother says it happened yesterday when her daughter accidentally knocked a cup of tea. On examination, you note a partial superficial burn to the lower back/buttock region. A total surface burn area is 4%. What is the most appropriate management? So burn centre referral for admission, and we'll go over the criteria shortly. So burns management. So basically what happens is, firstly, you lose the function of the skin. So the skin is an important barrier to infection. It is an important way that we control fluid loss, and it also controls our temperature. So if you lose the function of these things, you get hypovolemia, so loss of fluids, hypothermia, you can't keep warm, and infection because you lose a really important barrier. You also get injured tissue, which generates an inflammatory response, and that can cause further damage, protein loss, edema, and tissue injury. So in terms of the first aid, firstly, you want to remove whatever's burning the individual, and then you want to cool it. So the general advice that you would give is to run it under cold water for at least 20 minutes, and then you can wrap it in cling film. And because this basically is like a pretend skin or like an artificial skin barrier, it reduces the pain and it also reduces fluid loss. Now, when that person comes in to A&E or whatever setting you're seeing them, it's really, really important that you understand exactly what happened to them. So look at the cause of the burn. You want to know what first aid they've already given. Have an idea of the environment. So things like inhalation injuries or carbon monoxide. This is really important because someone might come in with quite extensive burns that you can see, but you need to think about any burns that you might not see, for example, airway injury. So for example, I've seen a patient before and it was a house fire and they tried to put it out and it was in an enclosed space. And so they went into an area with a fire and they had really bad burns all over their body. But what was more concerning was whether or not they had an airway injury. So it was really important to understand, did you inhale sort of smoke, hot air, and then look for things like singed nose hairs or a hoarse voice. Consider any other injuries and also consider if it's non-accidental, particularly in vulnerable groups. With your examination, you need to follow an A to E approach. You need to characterize the extent of the burn and the depth of the burn everywhere. And you need to pay particular attention to if there's involvement in special sites. Other key things to be aware of are circumferential burns, because these can cause compartment syndromes, and inhalational injury, as I mentioned, because you can get airway edema and loss of airway. In terms of burn thickness, so you can get superficial, partial, full thickness, or fourth degree, and essentially these describe the different extent to which the skin barrier layers are impaired. Things just to note are that superficial and partial are painful. This is because the pain receptors are maintained in these cases, whereas if you look at a full thickness burn, they're painless, or they're very insensate, because basically you've damaged a lot of the touch receptors in the skin, and so they can't feel anything. And it feels counterintuitive, but actually something that's painful might indicate that there's actually less depth of burn. And they also look very different. So you start, as they get deeper, at one point they become very white, and that's basically when this epidermal layer is completely gone. And again, that indicates a deeper injury. So it's really important to fully examine the patient and characterize the depth and extent of the burns. Now, in terms of fluid resuscitation, so firstly, this only applies to when the burns are of a certain extent. So in adults, 15%, children, 10%, and if there's airway burns. This is all because if you lose enough of your skin barrier, you're going to lose fluid, and so your fluid loss is going to be higher, so you're basically replacing the fluids that are being lost. And so as part of this, you also need to make sure that you're carefully monitoring general input and output. So you need to catheterize the patient and have a really good fluid balance. The Parkland formula is what describes how we calculate the amount of fluid that we give. And the calculation classically is 4 times the total surface area of the burn times the weight. And you can use things like this, which is the London, this is basically like showing the extent or like percentages. So essentially, you've got like the rule of 9s, which is that each region is kind of 9%. And then the final 1% is the genitalia and perineum. And in terms of the 9%, you've got head and neck, each arm, anterior, posterior trunk, and legs, and multiples of 9. And so you can use these to estimate the total burn surface area and then calculate the Parkland formula. It's worth just noting, though, that some people believe that this is a bit too much fluid, and actually the calculation, some say it should be 2 times or 3 times rather than 4 times. So just be careful and make sure you know what the most up-to-date formula that they advise for your local area in practice. So in terms of referral, this slide you can look at more later in depth, but key things to look out for are the surface area. If you've got a circumferential full thickness burn, because you risk compartment syndrome. If you've got special sites affected, airway burns, special types of burns, or any extremes of age, major trauma, non-accidental injury, then they should get a burns unit referral. Other things just to be aware of around the management of burns are if there's risk to the airway or respiratory injuries. Circumferential burns, you might need to do an escherotomy, which is basically where you like slash lines through the tissue to open it up and stop it causing compartment syndrome. And then electrical and chemical burns need specific management depending on exactly what's happened to them, and be more suspicious of them. Okay, next single best answer question. What are the 4 consecutive stages of wound healing? So they're hemostasis, the inflammatory phase or stage, proliferative stage, and maturation stage. So this is just something that is worth knowing about. There's 4 steps, and they take place over different periods of time. And if you look at this diagram in your own time, you can see what exactly is happening at each phase before you get healed tissue. Okay, a patient has undergone an incision and drainage of a left axillary abscess. After clearing the pus from the cavity and a thorough washout, the surgeon packs the cavity with Aquacel and applies a pressure dressing. The patient is discharged a few hours later. How will this patient's wound heal? So this will be by secondary wound healing. Okay, so you have 2 types of healing, primary intention and secondary tension. So primary is when all the dermal layers are closed. So essentially you stitch it up and then this heals by primary intention. How secondary intention is when the wound is not opposed. So in the case of this abscess, it was an open wound. You let it heal by itself. And the reason you keep it open is so that the infection doesn't come back. And that heals by secondary intention. Okay, next question. You are asked to see a patient who has presented 10 days following a right hemicolectomy for Crohn's disease. She has noticed some malodorous oozing from her scar site. You suspect wound dehiscence. Which of the following is not a risk factor for wound dehiscence? So the answer here is hypercholesterolemia. It's really important to know risk factors for wound dehiscence. So factors affecting healing and delay of healing. So you can divide things that affect wound healing into local or systemic. Other ways of doing it are kind of like patient factors and surgical factors, depending on how you want to break it down. So local, you've got the type, size, wound location, how well the wound was closed and its blood supply, if there was infection or foreign materials, and if you have radiation damage to the site. And systemically, if you're older, if you've got certain comorbidities, if you're malnourished, obese, or you smoke, these all impair wound healing. So wound dehiscence is basically a breakdown of the wound, and it's extremely serious if it happens. It's often seen in abdominal surgery because there's a lot of tension when you close say a laparotomy wound. And it's really important to pick it up early and be suspicious, basically, if patients aren't progressing very well, or if you see serious gangrenous fluid discharging. This can be an early warning sign. If you're not sure, you can do a CT scan to look to see if the abdominal wall muscles are intact, and it's a surgical emergency. So if you do suspect it, acute management would be an A to E approach, analgesia, swabs, bloods, and probably need surgery for relaparotomy and either primary or secondary closure. Next question. An 85-year-old woman presents to her GP with a painless leg ulcer. She has had compression bandaging managed by her district nurses for many years, but recently it was noted that the ulcer was changing in appearance with rolled edges. What is the most likely explanation? So this sounds like a Marjolin ulcer, which I will discuss shortly. A 60-year-old male presents to his GP with a painful lesion on his left greater toe. He has recently been started on an antihypertensive and statin following a routine checkup. His HbA1c is 42. On examination, the lesion is punched out and irregular in shape. The posterior tibial pulse is palpable. However, dorsalis pedis is difficult to feel. The left foot is cold to touch, and the calf is hairless compared with the proximal leg. You decide to measure the ankle brachial pressure index. Which value would you most likely suspect? So the answer is here 0.5 to 0.9. So just to go through this now, 3 is less than 0.3 is acute limb ischemia. This is a vascular emergency. 0.3 to 0.5, they would be a lot more symptomatic than they are here, and this is critical. 0.5 to 0.9 implies that they have arterial vascular disease, which is essentially what this vignette is trying to describe, but not to the extent that it's critical. 0.9 to 1.4 is regarded as approximately normal, and greater than 1.4 is when you have calcified vessels, such as from diabetes. But in this case, the HbA1c is 42, so it's implying it's well controlled, so it's not a diabetic limb that we're looking at. But when you get major calcification with diabetes, then you can see ABPIs that are paradoxically high. Okay, leg ulcers, lovely images here. There are 4 types, you could say: venous, arterial, neuropathic, diabetic, and pressure ulcers, and they all form slightly for different reasons and morphologically are different, and are also found in different locations. So people with venous ulcers often have other venous changes, such as venous eczema, hemosiderin deposition, may have varicose veins, and so on. Often you find them in areas such as the medial malleolus. And they're kind of these flat margins, got a lot of exudate, slough, or granulation tissue. And the way you treat them is shown here. Arterial, on the other hand, they're like punched out, they're deep, they're pretty painful. And you see other features indicative of arterial disease. Neuropathic ulcers are similar to pressure ulcers in that they're often in the pressure points, because basically diabetics can't feel their feet, and so they put pressure on areas longer than they should, and that causes ulcer formation, and you need special shoes or to offload the pressure basically to treat them. And pressure ulcers are basically the same, but it's more that someone can't move, say they've had a stroke or something, or they're elderly and bedbound, and so they stay in a position for too long and they form ulcers. And again, you need to offload them and do lots of tissue management. And a complication of venous ulcers is Marjolin's ulcers, which is basically a squamous cell carcinoma of the ulcer. And it's basically because of the chronic inflammatory changes that can develop, which is here. So yeah, so squamous cell carcinoma, chronically inflamed or scarred skin. It's not just chronic venous ulcers that can cause it, but it is a cause that often comes up in an MCQ. Often you see a change in morphology of the ulcers and they start to look a bit funny. You biopsy them to diagnose, and to treat, you typically need to excise them with the appropriate margin and really good tissue management afterwards, because you've got someone who's already not got the best blood supply in their limb. Okay, next question. A 35-year-old woman presents to her GP following a recent C-section. She has noticed her scar has enlarged in size and now extends beyond the original wound line. What is the most likely diagnosis? So the answer here is a keloid scar. The key point is that it's enlarged and it extends beyond the original wound line. So if it was just hypertrophied, it would still be within the original wound line. Next question. What is the tensile strength of a scar compared with normal skin following complete wound healing? So the answer here is 80%. And this takes a while. So this takes like at least 6 weeks to reach this point. And it's like an exponential curve of healing. And it's really important that when you start working, you see patients and they've got wounds, that they understand that the wound might look healed on the top, but all of the deeper layers, often such as the deep dermal layers and muscle, for example, they take a lot longer to heal. And so you really need to take it easy with wounds for the time that we advise, and also to be aware that it is a weak point in the skin generally. moving forward. And I learned that the hard way. Okay, so types of scars. You give a normatrophic scar, and then you can have sort of abnormal scars per se, which are hypertrophic, keloid, and atrophic. So hypertrophic are when they're enlarged, but they remain within the original margins, and they can thicken and then settle. So sometimes it just takes time. Keloid scars are caused by excessive wound deposition, and the key point is that they extend beyond the original wound line. They can also be painful and itchy. Some of the risk factors for keloid scarring are young age, dark skin, and genetics. So if someone has already had a keloid scar, or someone in their family has had a keloid scar, it's something to be aware of. The way you can treat them is with steroids and radiotherapy, and generally surgical excision, while possible, you want to avoid, because you're basically creating a new scar for the keloid scar to like form again. So yeah, I think if steroids and radiotherapy work, they're the first line really. And then an atrophic scar. So these can appear with things like acne, chickenpox, and they basically, when you don't have enough underlying fat, you kind of get like a dip where the scar lies, basically. Other things you can get with scarring are things like contracture, often happens following burns, and it can lead to tightness and restriction of movements, and that's why when scars are in like certain locations which are quite mobile areas, it's really important to do like, say, hand therapy if it's the hand, to make sure you move it as much as possible to try and loosen the contractures and keep the function of wherever is affected. Okay, next SBA, a 33-year-old female recently underwent bilateral mastectomy for prevention of breast cancer following identification of the BRCA1 gene. She is in clinic today to discuss breast reconstructive options. She agrees on having a DIEP procedure, which the surgeon explains is the transfer of a resected section of abdominal skin and fat to recreate the breasts, with anastomosis of a perforated vessel to the internal mammary artery. What type of procedure is this? So this is a free flap. So this is where you're transferring a bit of tissue completely from one location to another, and you plumb it in with a perforated vessel. So skin grafts and flap. Skin grafts, you can divide into split skin thickness grafts and full skin thickness grafts. In any case, they lack their own blood supply, and so they depend on the new site to form. The difference is basically what they contain. So a split thickness skin graft doesn't have the whole dermis on it, whereas a full thickness skin graft does. Typically you use the split ones for large areas because you need a really well vascularized area for the full thickness skin graft. But in both cases, things like a good blood supply in the recipient site and a lack of infection are really important to make these stick. Graft failure occurs, and this includes having a hematoma or seroma. Yeah, or if the bed's not good enough, so there's not good enough vascular supply, or an infection, for example. And basically you might see like pale or necrotic skin, or the person could have a venous infection or be unwell. Flaps, on the other hand, are kind of movements of larger pieces of tissue, and you can have lots of different types of flaps, basically. So you can have like free flaps, pedicled flaps, and the important thing is they come with their own blood supply or vessels one way or another. And essentially what you do is you can actually include in them skin, fat, muscle, fascia. You don't even have to have skin, you can just have the lower layers depending on the flap that you're building. And then basically you transfer them to a different site. So for example, here so this is the DIEP, so you basically chop this out here and you completely move it here. So this is a free flap. The example below is a pedicled flap. So this is where you don't cut the blood supply and and plummet in somewhere else, you keep the blood supply. We basically rotate the flap. So this is the example of a rectus femoris flap, which can be rotated to cover different regions of the abdomen. And another classic one is the latissimus dorsi for the breast. Speaking of breast, we'll move on to breast now for the last section. So next SBA, a 20-year-old female presents to her GP with a lump in her right breast. She reports first noticing the lump 1 week ago when she was in the shower. It is painless and has not increased in size. There is no obvious tethering to deep structures. She is not aware of any family history of breast cancer. On examination, you identify a 1 by 2 centimetre firm, smooth, mobile lump in the breast. On examination of the left breast, you note 2 further smooth, mobile lumps, each approximately 0.5 times 0.5 centimetres in size. What is the most likely diagnosis? So this is a benign fibroadenoma. Key features: young person with no family history, smooth, firm, relatively small lump, and there's multiple affecting both breasts. What are the 3 components that constitute a triple assessment for any breast lump? Examination, imaging, and biopsy. But just to note, don't forget history as well. It just doesn't constitute technically the triple assessment. A biopsy might not always be done, depends on the history. 52-year-old female with a background of hypothyroidism presents to your department with brown nipple discharge. She has recently entered the menopause and has smoked 20 cigarettes per day for the past 35 years. Triple assessment does not reveal any concerning features for carcinoma. What is the most appropriate management of this patient? Reassure and discharge. This is basically describing ductitation. A 67-year-old woman has been diagnosed with a 3 by 3 centimetre invasive ductal carcinoma of the left breast. On assessment, there was no palpable lymphadenopathy. She is being prepared for surgery. What is the most likely operative management of this case? So this is a mastectomy and sentinel lymph node biopsy. This is a bit of a tough one in terms of just knowledge of the size and what you would do. But this is removal of the breast, and then because you can't feel lymph nodes, but you still need to check if disease is spread to the lymph nodes by doing a sentinel lymph node biopsy. So breast lumps. This is a lot of information. Feel free to pause this and go through it in your own time. So breast carcinoma is the most common cancer in women in the UK, and its incidence is rising, and currently it's estimated to affect about 1 in 8 females, and it also can affect men, but it's a lot rarer and often genetically linked. Risk factors for breast cancer: so family history, including the BRCA genes, but also there's lots of other like polygenic associations, so it's not just BRCA. Age: the older you get. If you are nulliparity, so not being pregnant, having any children, or having a late pregnancy, so the first pregnancy over 30 years of age. Early menarche and late menopause, it's just having a longer estrogen exposure. HRT, obesity, not breastfeeding, and having previous breast cancer. For any breast lump, as well as taking a history, you need to do a clinical examination of both breasts. You do an ultrasound or a mammogram plus ultrasound, depending on the age of the patient. And you need to do a biopsy if suspicious. So you might do, if it's cystic, you might aspirate, or if it's solid, you do a core biopsy. And the reassurance can be easier if you've got a biopsy to support any findings. In terms of benign breast disease, so fibroadenomas, so this is what the first SBA was describing. So they often present in females under the age of 30, and they're completely benign, collagenous mesenchymal growths, basically. They feel firm, they feel smooth, and they're mobile. They're often called mouse, and literally, if you ever feel one, you can almost, like, if you kind of play the piano with your fingers, you can obviously appropriately when examine the breast, but if you move around your fingers, you can feel it moving around the breast tissue. And they're generally painless, and there may be multiple. Often an individual might feel one, but then when you ultrasound them, you start to find lots of like smaller ones that you just can't really palpate. And in terms of what happens to them, a third goes smaller, a third stay the same, and a third get bigger. Generally, you can observe and reassure, but you can also do ultrasound and biopsy. And if they're large, usually 3 to 4 centimeters or above, you usually excise them because there's a small risk they could be a phalloides tumor. And also other reasons to excise them would be cosmetic issues. So sometimes they can be very visible, and that can cause pain and discomfort as well. Other benign diseases are cysts and abscesses. And in these cases, you can either aspirate them or incise and drain them. And they kind of come with features as you would expect of cysts and abscesses. Duct ectasia often occurs around menopause, and it's when the ducts become blocked and the secretion stagnate. You can get green, brown, or bloody nipple discharge. You can reassure and discharge, but you can also just refer for confirmation of the diagnosis, but usually no treatment's needed. And if someone's a smoker and they have it, you advise them to stop smoking. Fat necrosis occurs after trauma to breast tissue. So a classic thing is if someone's in a car crash and they have a seatbelt over their breast, that can cause fat necrosis. And you get a firm lump, and often you do need to refer them because they feel like cancer. So they're often like irregular, craggy, firm lumps. But once you refer them, you biopsy them, you find out it's fat necrosis, no further treatment is required. Carcinoma. So there's different types of breast carcinoma. You have the non-invasive carcinomas in situ that can either be ductal or lobular. And these are like pre-malignant diseases. And for example, especially DCIS, what to do with them is slightly debatable, as in how far to go with kind of removing them. But these are kind of the pre-malignant states. You then get the invasive versions, and the most common is invasive ductal carcinoma, but lobular being a lot less. And there are other rarer forms of cancer as well. The majority of these cancers are estrogen receptor positive. They have a better prognosis, and they can also be treated with hormonal therapy. And you also get certain ones that have HER2 positivity. This is associated with aggressive disease and poorer prognosis, but treatment again with Herceptin reduces this. And in terms of how you stage them, use TNM. So prognostic factors for breast cancer: tumor size, grade, lymph node status, estrogen and progesterone status, and whether there's vascular invasion. And then Nottingham Prognostic Index is an example of a way that we can prognosticate individuals, and it's calculated with this equation here. In terms of how you manage breast cancer, it depends on things like size and patient preference. So if the tumor is small enough, you can remove it by wide local excision, maintaining the majority of the breast bulk. But if they're larger, you need to do a mastectomy. So that's removal of the whole breast. And then you usually do axillary node sampling or complete clearance, depending on pre-operative known lymph node status. Complications: scarring, seroma, and also nerve damage. And it's important to know which nerves are damaged and how you can identify them, because this can also come in exams. So sentinel lymph node biopsy, the reason they do it is because rather than removing all the lymph nodes and risking things like lymphedema in the arm, you just test the lymph node where the breast first drains to, and you can identify this with blue dye and radioactive dye. And if that's negative, then often you don't need to do any more. But if it's positive, you go back and you complete an axillary node clearance. And that means that you can reduce the number who have to have all the lymph nodes cleared. And it's quite an effective way of approaching lymph node clearance in breast cancer. Then in terms of other things that you do for breast cancer, radiotherapy is common, and often anyone with a wide local excision or even mastectomy will get it. It can cause things like pneumonitis, pericarditis, and rib fractures, and it can also sort of cause scarring and sort of an unfavorable appearance of where the breast has been removed. But and for example, if someone has an implant put in where they've had a mastectomy and they have radiotherapy, the implant often shrinks. But often you then do like a later reconstructive surgery once they've completed the radiotherapy, where you can return, you can improve the appearance of the breast if the patient feels or wishes to have that. Chemotherapy is also important and improves survival. You also have endocrine agents, which are really key in breast cancer. So if you're estrogen receptor positive, tamoxifen is used very, very widely. And you can also have aromatase inhibitors depending on if someone is pre or postmenopausal. And Herceptin is another agent that's used if you're HER2 positive. And then other things, it's important you have like breast care nurses, and then reconstructive options. There's a lot, and it's very much a patient dependent thing if they wish to have it, and then also if the specific type of reconstruction is appropriate for them. And that's a discussion that they can have later down the line if they wish. In terms of distant disease, long-term survival is possible. You have to do lots of scans, staging scans, monitoring. Things like radiotherapy can help manage painful bony lesions, because one place the breast cancer often spreads the bone, and different types of sort of chemotherapy can also manage spread of distant disease as well. So that's all for today. If you have any questions, feel free to put them in the chat. And if you scan this QR code, then you can give some feedback, and the QR code is available. It's open for a little while whilst the videos are on YouTube, so you can still look at it there if you wish.
Thanks again, Jess. And yeah, please do fill in the feedback form if you are watching on YouTube. And you'll also get access to the slides as well once you submit the form.